I welcome you all to our week-long celebration with UDC Workforce Development to really discuss the opioid crisis here in the District of Columbia.
It's more than just a number. These are people in individual lives. And so we really do, as a district, have to work hard to reverse this trend.
He didn't think he was taking the opioids. He thought he was smoking the weed. But the weed had been laced with the opioid.
Our patients are taking opioids to treat pain, but it's not physical pain. It's emotional pain.
In this area of service, it often requires going the extra mile.
As you probably all are aware, the opioid crisis is a major problem across the nation, and the District of Columbia is no different. And so we all know that this is all happening within the confluence of the COVID-19 epidemic or pandemic. And so kind of putting two pandemics together, this was a perfect storm to see this major increase that we saw. And so you can see that the medical examiner investigated over 1,600 cases of fatal opioid overdoses since 2016. If you focus on that light blue line right there, it's really showing you the trend over 2020. And you can see for most of that blue line, it hovers over any other lines that you see on that line graph, really. So that really should just communicate that there is a huge problem that we saw in 2020. However, we were trending up before that, right? And so I'd be remiss if I did not mention, in 2013, we had 213 overdoses. Even without the pandemic, in 2019, we saw an increase and saw 281. So even without the pandemic, we were already kind of amidst the throes of an epidemic that was really increasing on us. And we really were trying to grapple with reversing that. And so adding COVID-19 on top of that made it even that much more challenging. And lastly, just kind of point out where we are to date. As you can see, the purple, light purple line, we've had 197 opioid overdoses through the first 6 months of this year. And that's roughly similar to what we saw in 2020. In 2020, there were 214 during that same time period. But typically the medical examiner has some pending cases. And so that time, there could still be some cases from this first 6 months of the year that are not being displayed in that number. And so roughly the numbers are pretty similar to where we were last year for 2021. When we look at what really is driving this trend, right? So people want to know what is causing this increase. Well, overall, we all know that that increase has really been driven by the increase of fentanyl in the drug supply. And so if you focus on that dark blue line that shows you kind of this really increase we've seen since 2016. Since 2015, we had 20% of our cases that contain fentanyl, whereas in 2020, 94%. So it's a dramatic increase over that 5, 6, 7 year time period, right? And in this work, right? As an epidemiologist, a lot of times I'll show data, right? And as the medical examiner's office is death data, right? And so, but one of the key things I like to remember and point out is that these are individuals and loved ones who, did not wake up that day. And so their families, their communities, their friends are missing them. And so it's more than just a number. These are people in individual lives. And so we really do, as a district, have to work hard to reverse this trend. As you look at some of the successes that the Live Long DC strategy to address the opioid crisis, there has been some accomplishments. And just so you know, that is the district's plan and blueprint to address the opioid epidemic. And so it is a collaboration of many district government agencies as well as community-based organizations to really do a district-wide approach to that. It's not likely that having government be the sole focus of the efforts, it would be effective in really reversing it. It really has to be a district-wide kind of approach to reversing this epidemic. And so I'm glad to see that this plan has had some accomplishments despite the trends that you've seen. So one of the main accomplishments that they've had is doubling down on the naloxone, right? And so they saw this 85% reversal since launching Live Long DC in the number of opioid overdoses that were successfully reversed, right? And so we know that really getting naloxone out there in communities and in individuals' hands can save lives, right? And so that is a really important measure that I think the district as a whole is working hard to do. also awarding grants to faith-led organizations and institutions. As I said, part of this work is really getting the message out and letting people know about the crisis, letting them know about the drug supply, not to use alone, but also letting them know where to obtain life-saving measures. And so the more that you can bring in community-based organizations and faith-led or institutions, the greater the success or likelihood of success can be. And also operating or really supported 2 or 4 peer-operated centers that focus on serving individuals with opioid use disorders. There's also some promising and new strategies. The plan that was originally created in 2018 actually went through 2020. So in 2021, there was a new plan that was launched and released, and it includes several new strategies. One being, as a data person, I'm definitely interested in this, but using data really to drive outreach and prevention efforts, right? And so now using data that is captured through fire and emergency medical services, whenever someone experiences an overdose, that information is reported, and outreach workers are now deployed to those neighborhoods and those hotspots within a 24-hour period to deliver information on kind of this tainted drug supply, but also to allow people to receive naloxone, other information and support. So that's really a really promising and new strategy. DBH continued on launching educational campaigns. So they had the Text to Live campaign, as well as DC Health has launched an educational campaign as well. So really making sure that we're really getting the message out and informing residents is an important strategy. And also increase the capacity of the emergency department medicated assisted treatment induction program. And so by bringing in 2 additional hospitals, there's now 6 hospitals that are able to provide and link individuals who may experience an overdose into care and to support. And so that's a really important part. And when that's being a pair, there's also a new component of that where there's a pair-led individual that really tracks that individual and follows them after discharge to help support the linkaging to additional care and needs. And so there's a lot of promising and great work going on in the district.
One of the reasons that I think this week-long program is so important is because the stigmas that we have associated with Black addiction has been very different than the stigmas that we associate with white addiction. And part of that comes because there have been various derogatory terms that have been used to describe African Americans, including terms that are supporting a frame that Black people are inferior, dangerous savages needed to be tamed, and we over-police Black communities because of that. We treat Black people's addiction as a crime instead of a health crisis that we consistently hear about. I want to rewind for a minute into the legacy of devaluing Black lives in the 70s with Nixon's war on drugs. Because I'm going to actually share my time with Jay-Z, because I think Jay-Z does such an amazing job of contextualizing this whole war on drugs, as Nixon put it. And the contextualization of that Jay-Z does, it really brings home how we got to where we are, where Black communities have not been getting the treatment that has been so badly needed for so many years. Why has we've gotten to the point where Black communities, haven't been able to come forth because of stigma, and we haven't been getting the funding and the support, and our community hasn't been coming out to get that support when it is available. So this video is I think it's about 4 minutes. I normally wouldn't do this, but I think it's valuable to hear what Jay-Z does, and those who have seen it, perhaps looking at it through a different lens. How are we doing now?
Yep, good, we can hear it.
Perfect, thank you.
In 1986, when I was coming of age, Ronald Reagan doubled down on the war on drugs that had been started by Richard Nixon in 1971. Drugs were bad, fried your brain, and drug dealers were monsters. The sole reason neighborhoods and major cities were failing. No one wanted to talk about Reaganomics and the ending of social safety nets, the defunding of schools and the loss of jobs in cities across America. Young men like me who hustled became the sole villain, and drug addicts lacked moral fortitude. In the 1990s, incarceration rates in the US blew up. Today we imprison more people than any other country in the world: China, Russia, Iran, Cuba. All countries we consider autocratic and repressive. Yeah, more than them. Judges' hands were tied by tough on crime laws, and they were forced to hand out mandatory life sentences for simple possession and low-level drug sales. My home state of New York started this with Rockefeller laws. Then the feds made distinctions between people who sold powder cocaine and crack cocaine even though they were the same drug. Only difference is how you take it. And even though white people used and sold crack more than black people, somehow it was black people who went to prison. The media ignored actual data to this day. Crack is still talked about as a black problem. The NYPD raided our Brooklyn neighborhoods while Manhattan bankers openly used coke with impunity. The war on drugs exploded the U.S. prison population, disproportionately locking away black and Latinos. Our prison population grew more than 900%. When the war on drugs began in 1971, our prison population was 200,000. Today it is over 2 million. Long after the crack era ended, we continued our war on drugs. There were more than 1.5 million drug arrests in 2014. More than 80% were for possession only. Almost half were for marijuana. People are finally talking about treating addiction to harder drugs as a health crisis, but there's no compassionate language about drug dealers. Unless, of course, we're talking about places like Colorado, whose state economy got a huge boost by the above-ground marijuana industry. A few states south in Louisiana, they're still handing out mandatory sentences for people who sell weed. Despite a booming and celebrated 50 billion legal marijuana industry, most states still disproportionately hand out mandatory sentences to black and Latinos with drug cases. If you're entrepreneurial and live in one of the many states that are passing legalized laws, you may still face barriers participating in the above-ground economy. Venture capitalists migrate to these states to open multi-billion-dollar operations, but former felons can't open a dispensary. Lots of times those felonies were drug charges, caught by poor people who sold drugs for a living, but are now prohibited from participating in one of the fastest growing economies. Got it? In states like New York, where holding marijuana is no longer grounds for arrest, police issue possession citations in black and Latino neighborhoods at a far higher rate than other neighborhoods. Kids in Crown Heights are constantly stopped and ticketed for trees. Kids at dorms in Columbia, where rates of marijuana use are equal to or worse than those in the hood, are never targeted or ticketed. Rates of drug use are as high as they were when Nixon declared the so-called war in 1971. 45 years later, it's time to rethink our policies and laws. The war on drugs is an epic fail.
Some barriers to prevention for success. These are 4, I think, key statutes or drugs or policies or initiatives that prevent people from recovery. We have the Drug-Free Workplace Act that really prevents people from returning to work because often there's mandatory drug testing in so many employers. DC, I'm going to often give DC credit because I think one reason I have loved this city so much is because DC understands how laws create barriers instead of helping with recovery. So Drug-Free Workplace Act, in many instances, those receiving federal funding or some kind of federal contract have to create a policy that says we support a drug-free workplace. The problem is so many employers have turned that into mandatory drug testing instead of giving out a flyer and saying we support drug-free workplace. Social Security disability insurance. In many of the videos that we watched earlier, some of the recovering members of our community mentioned that they have connected mental health disabilities that go along with their addiction. So Social Security disability is that safety net. It's a safety net for many things that may happen in our lives. And the problem with the Social Security barrier is if there's a nexus between the disability and the drug addiction or alcoholism, then that can be a barrier to actually being able to receive Social Security disability. Temporary assistance to needy families, our TANF benefits, same kind of barriers can exist. Again, DC took an initiative, unlike there are 17 other jurisdictions that require mandatory drug testing and will remove someone from receiving, deem them ineligible for TANF benefits if they're a repeated drug test positive. DC, again, has opted out of that provision But as I hurt, if my neighbor hurts, I hurt. So I am also still concerned about those 17 other states that still have these provisions in place where someone is prevented from getting temporary assistance to needy family, one of our public benefits, one of our safety nets, if they're positive drug tests. And then access to housing. Housing is so expensive in DC, as we all know, but that's another initiative that creates a legal barrier to successful recovery. That if you have someone who has a felony, if you have someone who has chronic drug addiction, that can be a bar to public housing as well. So what are the prevention strategies? I think the first thing we have to do is remove that punitive framing that has accompanied drug addiction for so many years. And removing that framing is how we begin to see funding coming into our community. And providing full benefit access. Public benefits should be there for everyone. Public benefits are there as a safety net. When you take away the safety net, of course, recovery is going to be more difficult. And then the final thing is removing drug and felony bans in employment so that recovery, I'll just be very transparent. My father lived with a heroin addiction for years. And the man, a brilliant man, no longer with us, but a brilliant man who struggled with his addiction and struggled with employment and struggled with finding employment because of the various criminal convictions he had on his record. So, again, I say that these issues are personal to me. They're personal because I see how they destroy lack of recovery programs, destroys individuals, families, communities. And I will stop there.
We also seen that a move towards self-medication. I think about a client I had who has sickle cell disease. He was like 13 years old, and he felt that he was in chronic pain. And when these pain episodes hit, his way of dealing with that was through the opioids. Now, to the point which was made, one of my students brought this up as well. He didn't think he was taking the opioids. He thought he was smoking the weed. But the weed had been laced with the opioid. I've been working in this field for about 30 years. And my first exposure to this was working in a maximum security detention center in upstate New York. We had kids coming in from Rikers Island who were in Rikers Island that had been transferred to our treatment center up in upstate New York. And what I noticed about them, aside from their substance abuse, is that all of them had had extreme trauma exposures. We had children who had been abused, neglected. One child was set on fire. They've had sexual abuse experiences, psychological abuse. And we know that not everyone who has abuse experiences or trauma exposures becomes addicted to drugs. We know that to be a fact. But in some of our cases, we've seen that. And that's been the area of my focus for the past 30 years, is looking to the extent to which trauma explains it. And what undoes trauma, it's almost like Carter G. Woodson, I'm channeling him right now, the miseducation, is the miseducation piece, isn't it? So if trauma has been put there psychologically, then we can remove it by certain treatments, some counseling interventions that we utilize here. And I'll talk about my work doing that in a second or so. But the approach that we use is called the biopsychosocial perspective on understanding theoretically what must be going on. So the biological part are things that could be genetic or epigenetic type of activities. It could be physiological, it could be hormonal, how our endocrine system responds to different levels of stress. And we know that the stress and the stress hormones interact in a way to tell the body to make a reaction or not. So many of the people that we work with are under chronic stress. Now there's a new one that's popped up last year that kind of went away. It's called carfentanil. So, and I understand from my people that work in this field that the carfentanil is even stronger than fentanyl. So, and we're talking about substances that are essentially poison. We're not talking about substance abuse here. We're talking about a poison prevention. So I wanted to put it in that perspective. These drugs were never designed to be drugs of abuse, or like heroin was, or like marijuana is, or alcohol. These drugs had other destinations and other capacities to use.
My first question to you all is, what are the opportunities and challenges youth feel about living a drug-free lifestyle? I know sometimes it can be hard, especially in DC. I'm born and raised, but tell us about some of the challenges and opportunities that presents when trying to live a drug-free lifestyle.
Being able to accomplish as much. And what I mean by that is there are many drugs that can be used in order to enhance performance or to help you stay focused. And sometimes, especially if you're going to a really competitive school or attending college, keeping that mentality, stay encouraged and keep going and to finish your work, that can be really hard. And a lot of students rely on drugs in order to do that. Living a drug-free life, it eliminates that factor, and you just got to run on yourself. And at times that can be a really big challenge.
What impact does social media and popular culture have on youth drug use? I was listening to the radio actually on my way here, and I was listening to Frank Ski and Nina Brown, and they made a comment that was very interesting, or they were replaying actually Ron Moulton. They were replaying him, and they were having an interview about the gun violence. And he said, you know, you'll have somebody on a radio station talking about shoot it up, go get some needles, shoot it up, and da-da-da. But then it's let's have a peaceful protest against drugs and all of that. So what impact does social media and popular culture have on youth drug use? Not that I'm saying that they are correlated. I'm just saying that, you know, I want to ask you all, what impact do you think it had?
They really only talk about like the good effects of drugs, like especially in rap and other, it's not even just rap. People like to group it in with rap, but then there's a few other things like pop where they talk about it, but they never really talk about the downsides. They never really talk about like the withdrawal symptoms, you accidentally getting addicted, the adverse effects. They never really talk about that. They only really talk about the high, you having fun with your friends at parties and all this stuff. They never really talk about the lows. And especially with social media, with a bunch of people just like posting them smoking and stuff and doing all that, I feel like Prince said, it really pushes this agenda that like all the cool kids do drugs, and like drugs are this normal thing. You shouldn't really like, oh, drugs aren't this big thing. Like, oh no, you shouldn't be scared of them. It's just weed. It's just this, or yeah.
I taught for 8 months and 2 days, and I taught 12th graders. So I understand the impact of that. My question is, do you feel supported trying to live this drug-free lifestyle? I know, you know, organizations like the War 7-8 Prevention Center are here to support us. However, other entities, they just can't do it alone. It comes with some partnerships. Do you think youth feel supported in that mission?
I would say as a family or with family and being inside of a home, I feel supported, but I feel like living in Ward 8, going outside your home, it's support in the community, but once you live in like Southeast and Southwest and stuff like that, it's like going into the street, you have people jumping at you, like, oh, I got this, you want this, oh, well, you're beautiful, I'll get you this. It's kind of, you're not supported because they're throwing it at you. But it's like when you're in home and your family's not doing it, or they're keeping it away from you, you're more supported. So it's kind of like yes and no.
You could go in any corner, right outside our offices, on MLK Avenue Southeast, Good Hope Road, Malcolm X Avenue, a few other spots throughout the city. You couldn't get bottled water during the pandemic. You couldn't get distilled water. You couldn't get spring water, but you could get a bag of fentanyl. You can get a bag of heroin. You can get K2. You can get cigarettes. You can get beer. You can get alcohol products. You can get all of these products, but you couldn't get paper products. In some of these communities, you can't buy a nutritious meal, but you can get some meals that are high in fat content and high in cholesterol. And I know this is kind of off the subject as it relates to opioid use, but it speaks to some of the other underpinnings and social determinants that lead us to the condition that we're in. So when you talk about wraparound, I think collectively, everyone has a role and a part that they can play and get involved in addressing this issue beyond a shadow of a doubt. And the people that need the most help, even as we conduct this panel and have this discussion, are not on the panel. They're not getting this firsthand information. So it's my responsibility to take what I'm learning here and transfer it into the community to that person who may not even be able to tell me what their problem is. They just come up to me and say, well, I need a sterile syringe. I want to exchange syringes. So what we do is we're on the front line. In this area of service, it often requires going the extra mile. People just don't come packaged in nice, neat bows with all their ducks in a row. I remember there was a situation where a gentleman was physically detoxing, and he was too physically sick to really navigate through the assessment process to allow him to engage with medical assisted treatment. And this was an older gentleman, and it required me like bridging the gap between himself and the person doing the assessment. And the bottom line was this man who had, been chemically addicted and in and out of active addiction and in and out of the system for years, said to me, he cried, he literally cried and said, this is the first time someone really helped me. And I'm sure Dr. Chapman and others have had these kinds of personal experiences dealing with individuals who you're servicing. But it just further reinforces to me how essential it is to be able to go the extra mile, because sometimes you can get into a comfort zone and if it doesn't meet within a certain time frame and having an agenda and needing to have a things to do list and forget about the person who's on the other side of this desk or who's on the other side of this service, who is being handed the syringe. If I over the past fiscal year have distributed over, and this is and I'm ballparking this figure, but it's well over this factually, over 100,000 syringes. One syringe represents one person. And I don't see numbers, I see people's lives. And as Dr. Chapman so clearly stated, we can't treat a person who isn't alive. So we can't assess the value of the life before we save the life. And saving the life may mean putting a sterile syringe in that person's hand. Saving the life may mean equipping them with the overdose prevention and education and giving them Narcan so that they can use on a partner or a colleague or whomever they're using with who may overdose. It begins with, first of all, us educating ourselves as to what a stigma is and where it comes from. First place. The second thing would be to understanding that the substance use generally is a symptom to an issue or dilemma or disorder that probably has not been addressed or maybe undiagnosed. And we have a tendency to put people in categories, and we codify and classify people in all kinds of ways. And in doing that, it thrusts upon those people this negative perception based on behavior. But we need to educate ourselves. We need to really educate ourselves and dispel some of these distortions that we carry concerning people, because the bottom line is, you never know how the table can turn. We a lot of times I think we see ourselves as being insulated from some of the ills of the people that are suffering from some of these things. But we never know that one thing, and you're a psychiatrist, so you understand that there's one thing, the wrong thought going through my brain at the wrong time can cause me to come unraveled.
our patients are taking opioids to treat pain, but it's not physical pain. It's emotional pain that they're treating. And about 3 years ago, Dr. Ayanna Jordan at Yale, Black psychiatrist, published a paper, and in that paper basically said what we've seen over and over again. If you talk to our patients, most of our patients started with street drugs. They started with heroin. They started with cocaine. They started with PCP, but they were not treating physical pain. They were treating emotional pain. And then when you dig into those histories and show them that they were treating pain, they were treating emotional pain, you will find that there was trauma in their childhood. And now we talk about adverse childhood experiences, adverse community environments. We're seeing that every day with the shootings in our community. How traumatic that is growing up in that environment. What does that do to your synapses in your brain when you can't sleep because you're worried about getting hit by a stray bullet?
Thank you everyone for joining us today. This is the last day for a week-long celebration that we've had for National Recovery Month. Thank you for joining us. We have been working with the UDC Workforce Development and Lifelong Learning to host this inaugural week-long opioid prevention strategies virtual workshops. As I stated earlier, this is the last day of the workshop. Today's theme is Thriving Thursday, and we will have it as the DC Department of Behavioral Health Day. We will talk about accessing and navigating resources and community services at the University of the District of Columbia. And we hopefully will have a provider on as well. We will also talk about the workforce and what workforce is needed for treating recovery and treatment programs. Again, this project is funded by a grant from the DC Department of Behavioral Health, part of the Live Long DC campaign on opioid awareness. The bios of all of our presenters will be available online at UDC's website.
We have more overdoses. We've shown that we really need more people out there handing out Narcan, because Narcan is specifically an opioid overdose prevention drug. So when those individuals overdose, we need Narcan next to them right then, and the idea is that we need everybody, bystanders, stores, wherever you can get Narcan, someone needs to be able to bring it to that individual then, because that's how we prevent the deaths. So that's really key about getting and working with individuals. And as Sari mentioned, trying to work with individuals to reduce the stigma and reduce the judgment, make it more just easier so you feel more comfortable about it. Making sure people are aware of the Good Samaritan laws, because you always, I hear this all the time still, people, and it's understandable, but, a lot of people think that, well, I don't want to try to use Narcan and bring somebody back, because if they die, then I can be held liable. And we live in a very litigious society. And so people think that, hey, I can be liable, I can be brought up on criminal charges, et cetera. And, the Good Samaritan law states that that's not the case. If you help someone and, you're not going to be held liable for anything that may happen to them. Narcan is only there to help. So we really want to make sure we can get that out there as much as possible, because ultimately, this is a huge issue. And I think the more we go on, we see that it's something that's really hard to confront, because you mentioned the carfentanil, even though we may not be seeing it right now, it's something that might be on the horizon. So we're always looking at, we think we're making progress in one area, and then you have something else come. So you're constantly sort of working against the tide. So you want to make sure you have some of these safety outputs as in as many places as possible.
Today's training, there was a gentleman on there that had just completed a training with Narcan, and Uber driver said, "Hey, does anybody know? I got somebody passed out in my car. Can y'all help?" And people came out. He had his Narcan on him. He had the kit, and he had to administer, I believe, both of them actually. The person came through, and if I'm not mistaken, they refused transport for medical care, and the person went back out. So someone else had Narcan because it wasn't Narcan training, so somebody else had to give. But it was just the weirdest thing. So they refused transport. The second time they went out, they went for medical care. So just to let you know that whatever and the amount of opioids that was in their system obviously was a whole lot, that they had overdosed twice, even after receiving life-saving measures. So I appreciate having this. I think if people knew that this was available and the benefit of it all, and I believe that it's because it's really removing the stigma of helping someone too, so all of these conversations are coming in at the same time so that we can help others.
Yeah, I mean, what you touched on, Nora, we cover in our training, but I think it is important to emphasize. So Narcan usually lasts in your body about 30 to 90 minutes before it begins to break down. But most opioids are going to last 3 hours or longer. So what you described about the person overdosing, being brought back with Narcan, and then overdosing again, it's actually not that unusual. It does make it important to get medical care and for people not to be alone. But yeah, it's a lot of people think like, oh, you give someone Narcan, they're going to be fine. And I mean, a lot of the time they are fine, but yeah, it's definitely possible to experience a second overdose, even if you haven't used. So
thank you to all of our speakers and presenters that have been on this week. We've had some fantastic panels and the after conversations that it seemed to go on forever, but they've been so wonderful. I really want to thank the young folks that got on Tuesday, Rashawn Bell, Kayla Valentine, and Prince Green, and it was moderated at the last minute by my nephew, Nathaniel Green, no relation as far as I know, and Kimry Hughes, who manages the Marion Barry Youth Leadership Institute. So I definitely want to give a shout out to these individuals, as well as the Ward 5 Drug-Free Coalition. But none of this could have happened without a very team-focused, collaborative partnership with UDC and Dean Smith, who valued and understood the value of what we were trying to do. And so I really want to say thank you, UDC. Thank you, President Mason. Thank you. We look forward to continuing this partnership and to grow and expand, because it's definitely necessary and important. So thank you, everybody. There was a staff member that was on staff under Dean Smith that has moved on to a different job, and she was very instrumental in moving things forward. I would also like to thank Mr. Sherman Cook as well. And I'm going to give kudos to one of my friends and colleagues, Wayne Sparks, who was the spark that got everything started. You guys may not know this, but he really helped connect us with the dean over at Workforce Development. So I want to thank you, everybody. This is part of the Live Long DC campaign, as Dr. Barker, Orlando Barker mentioned, and this is a citywide effort, and multiple people are working towards really addressing the opioid crisis, but also bringing it down. And I want to express to our young people that there's a way out. If you view any of our videos, these videos are all going to be up on the Ward 7 and 8 DC Prevention Center YouTube. So you can go to YouTube and download these videos and learn some great information. We've had wonderful speakers, great information, and we would hope that you would all join us in really supporting prevention on the front end. But if you can't do it, treatment and recovery on the back end. And this is National Recovery Month. And so we want to really support individuals that are in recovery. My father has been in recovery for 29 years in December, and I want to continue to support him and support all those individuals to be able to live a drug-free lifestyle, but to do it in a safe way and in a supportive community environment. So first of all, thank you. Thank you, Roz Parker, for giving me a lot of leeway. And if you know how I work, Roz gave me a lot of leeway. So thank you. I want to thank my colleagues, Stephen Hazel, Geraldine Bolden, Brandon Bridges, and Dr. Lauren Ramsey for all of their work all year long. It has been an amazing year. And thank you for allowing me to come back on, Mr. Hazel, and join you and Roz again.